ચાલો મારો સ્ક્રીન આવી ગયો ને. હેલો.
યસ સર, યસ સર.
ચાલો.
હા સર, ચાલુ કરે. સેટ ઇન્ટ્રોડક્શન.
હા હા હા.
Good evening, doctors. Regards from Abbott India Limited. Myself Jignesh sir, and sorry for the delay due to some technical error. So without wasting time, now we are starting the webinar. So today we have very eminent and very renowned speaker, Dr. Manish sir, from Surendranagar, and he will be talking on the topic recurrent implantation failure, a unique riddle. So sir, over to you, sir.
Thank you, Jignesh. Thank you, Abbott, for giving me opportunity again and again. Today I am going to speak on recurrent implantation failure, a unique riddle. Believe me, it is a basic riddle. This is my credentials and would like to everybody to enroll on ORCID. Yesterday my 57th paper has been published and I got 2 seats of diploma at my place. The moment child is born, mother is also born. She is there, mother is something new, said by Rajnishji. And how beautifully everything is arranged by Almighty, that as soon as child enter into this world, mother is ready to take care of it. The blessings of mother of mine, 3 books written by us is recommended in Royal College as a reading material. Atlas Hospital Choreography has gone for 2nd edition. Likewise, the technique of IVF made easy is also available as a 2nd edition. And I am editor-in-chief of 2 journals. Recently, I got opportunity to take interview of Professor Herman Tourne at Esre in Copenhagen, and this will be available on my YouTube channel Manish 4269. Today, I am going to discuss something regarding the overview of recurrent implantation failure. Just hide window. Okay. Overview of recurrent implantation failure. What are the risk factors and what is the pathophysiology involved in recurrent implantation failure? What investigation we should do and what is the therapeutic intervention available in recurrent implantation failure. If we see on the overview, we must see that implantation is also depends upon the quality of embryo receptivity, embryo quality and microenvironment around the signaling. See, we must know that if soil is good, endometrium is good, crop is good, naturally there will be no recurrent implantation. Professor has published literature on endometrial receptivity, and they said that at the time of implantation, if there is good pinopodal activity, there will be very good alpha V beta 3 integrins, and embryo quality is good with good osteopontin at the level of embryo site like this, then this embryo is naturally going to implant by intrinsic implantation by eroding our mother's endometrium by phagocytosis done by syncytotrophoblast and cytotrophoblast. We are implanting our cell into our mother's endometrium, and this will give a microenvironment signaling between the mother and fetus, and this is very good. Then there will be no discussion of this recurrent pregnancy loss. If soil is not good, crop is not good, and our khatar, that is fertilizer is not good, then there will be no good embryo implantation into the endometrium. If we see the definition, recurrent implantation failure definition does not have a universal definition consensus. The European Society of Human Reproduction, that is ESHRE, they said that pre-implantation genetic PGD consortium defines RIF as a failure of achieving clinical pregnancy after more than 3 unsuccessful transfer or after more than 10 embryo by multiple transfer. So they are providing 3 to 4 embryo transfer per cycle. If it is not good, then it is a recurrent implantation failure. Likewise, the British Fertility Society also said that absence of positive pregnancy test after 3 consecutive pregnancy loss, that is known as recurrent pregnancy loss. If we just see the incidence of recurrent pregnancy loss worldwide, it is 10 to 15% of unrecognized pregnancy or pregnancy they are undergoing IVF and embryo transfer. Believe me, this is very big ratio, because out of 10 patients, 1 to 2 patients who are suffering from, even after they are implanted, they are going for recurrent implantation. What are the risk factors involved in this? Most important is advanced maternal age. Patient doesn't come to you when they want to do IVF in earlier age. Patient with high BMI. Nowadays, smoking is very culminating factor. Alcohol consumption. People are thinking there's a high society, alcohol should be there, but they will make your life very bad. And because of that, the stress and quality of life is not good. We should not forget our male partner, that male is also contributing a bigger role by DNA fragmentation in the continuation of recurrent implantation failure. What is the effect of age? The magnitude of odd ratio of recurrent implantation failure is lower in younger women if they are less than 35. Aging in women causes reduction of ovarian reserve and oocyte competence. Advanced maternal age impacts fertilization rate, embryo development to the blastocyst stage, and aneuploidy rate. You see, aging is also affecting very bad. You can see at the time of a generation there are lots of egg. When age increases, the quality of embryo and number of oocyte decreases, and aging of ovary is 1 year more than the age of woman, because ovary is the first gonad, or SRY gene, that is sex representing gene is there, and they are deciding that this embryo is going for male or female. Likewise, obesity. It exerts its effect upon the conception, implantation, through a cumulative implantation failure by several processes. Obesity affects ovulation, oocyte maturation, endometrial development, uterine receptivity, implantation, and miscarriage. If we see figure on this side, we can see that we should be thinking of HPO axis, hypothalamo, pituitary, ovarian, uterine axis. Everywhere this obesity affects. If you see in male and female ratio, they had conducted a very good trial, retrospective trial involving more than 22,000 frozen embryo transfer cycle, and they demonstrated that obese woman has a significant decreased chance of implantation. If we adjust odd ratio, that is 0.80, clinical pregnancy rate odd ratio is 0.81, and live birth rate odd ratio is 0.7 only. Same wise, the male with higher BMI over 28 kg per meter square exhibit a significant lower fertilization rate, decreased quality of embryo rate, and reduced clinical pregnancy rate compared to their normal BMI counterpart. They also had an increased sperm DNA fragmentation rate and short-term sperm telomere length. This is there for male also. Noxious effect on smoking. You can see people are nowadays smoking more. Each stage of reproductive function, folliculogenesis, steroidogenesis, embryo transport, endometrial receptivity, endometrial angiogenesis, uterine blood flow, and uterine myometrium, all are affected by smoking. See, I am great, that's why I am smoking. Smoking patients have lower estradiol level during ovulation stimulation. Smoke requires twice number of IVF cycle compared to non-smoker. Smoking has got negative effect on endometrium thickness on the day of embryo transfer. Even the passive smoking, male is smoking and female is just inhaling carbon monoxide. So second-hand smokers was associated with 52% of higher risk of implantation failure and 24% reduction in the live birth. Likewise, alcohol. Consumption of alcohol affects a very detrimental effect on reproductive function. If you see the effect of alcohol on steroidogenesis, there is an increase in estrogen and decrease in progesterone level, decrease in hepatic oxidation of estradiol to estrone, decreased expression of LH versus HCG receptor in granulosa cell. If you see effect on oviduct, decrease oviduct smooth muscle contractility. So it also impairs the IVF, it also impairs the normal pregnancy. If you see the effect on uterus, pre-implantation development effect will be there, decreased cytotrophoblast cell proliferation and increased apoptosis. As I had already told, that syncytotrophoblast and cytotrophoblast are required for erodation of endometrium, for putting embryo into the endometrium, and we are implanting our cell by eroding our mother's endometrium inside the endometrium, above the myometrium. 18% greater odds of failed implantation among women who drinks 1 to 7 drinks per week square, and women drinking white wine weekly has got 22% greater odds of failed implantation. So people are saying that wine is good, here wine is also not good. Men drinking beer daily have got greater likelihood of failed implantation. So what is required for successful implantation? Stressful life. Individual response to stressful stimuli can differ dramatically, conveying to a major issue of stress response rather than stress itself. If we see on this slide, there is vicious circle associated between stress, quality of life, and altered female fertility. Stress is common for both pre and post IVF cycle. In patients with low cortisol level on the day of egg retrieval, chances of pregnancy were significantly higher. Compared to IVF, failure leads to higher rate of both anxiety and depression in immediate future after negative IVF outcome. So we should reduce our stress in pre-IVF as well as post-IVF patient, and we should cut short about this quality of life, stress cycle, altered abscessness, so everything should be less. Don't forget our male partner. Male has got high order of recurrent implantation failure in IVF is associated with male infertility. The factor responsible for male fertility, that may be due to chromosomal abnormality, sperm factors like thumb chromosome, gene mutation, and quality of sperm. We must not forget the paternal age, miscellaneous factor like menin binding protein, that is MIB, therapeutic agents something like air pollution, certain medication, ionizing radiation. Studies have demonstrated that the deoxy, that is DNA fragmentation, to be associated with reduced natural conception, even in IUI, and fertilization and pregnancy rate in ART cycle. The performance of sperm cell of poor morphology is low, and it is correlated with high rate of DNA fragmentation. 28% of sperm cell of infertile male exhibit DNA fragmentation compared to only 13% of those who have got fertility. What is pathophysiology regarding the recurrent implantation failure? Achieving implantation strongly depends upon the proper structure and adequate receptivity of the endometrium. The various factors essential for creating in vitro fertilization, appropriate endometrium receptivity, trophoblast proliferation, and embryo nesting. This must require very good synchronization between Th1 and Th2. COVID had taught us very good regarding the antigen-antibody reaction. Whenever there is antigen striking in our body, we must thank Professor Raj Raghupati. They had given very good notion of allogenic immune response to paternal antigen. So many times, uterus considering sperm as an antigen. Again, that sperm, maternal body develops antibody, and that embryo, when it implants into the uterus, body consider it as an antigen, and against that antibody formation will be there, and that embryo is rejected. There is a very good paper published in 1919 by Clark and al. It depicts that why your mother has rejected you, and they are giving very good immunomodulation or immunity remnants that what is there when there is a recurrent implantation failure. For that, we must require modulation of the COX-2 and MM3 expression. VGF3 and PIGF angiovasculogenesis should be there. For endometrial receptivity, state is very good. Natural killer cell activity of peripheral and uterine natural killer cell, it should be appropriate for vascular pattern, decellularization process, trophoblastic proliferation, and embryo nesting. If everything is good, then this embryo is going to implant into the uterine endometrium, and if it is not there, sorry to say, there will be implantation, but embryo is not growing, so they are going for recurrent implantation failure. What is there a mechanism involved in recurrent implantation failure? There are various methods. You can say there are immunological, that is Th1, dysbiosis, infection, that is chronic endometritis, even endometrial thickness, anatomical abnormality, genetic abnormality, and sperm morphology. All these 7, like Monday to Sunday, if it is there abnormal, then we must say that patient has to go for recurrent implantation failure. And if you want to cure this patient, we have to take care of all these 7 different factors in different modality, and we have to clear this notion, and we have to give very good baby in our hand, because ultimately end of the day everybody wants very good potential or fertility. If you see this slide, the events entailed in implantation failure leading to inadequate pregnancy maintenance in recurrent implantation failure. When uterine natural killer cell presented with increased number with an abnormally increased cytotoxic phenotype, all the events entailed in normal embryo implantation are dysregulated. Due to their increased cytotoxic phenotype, these abnormal uterine killer cell, that is UNK cells, attack and destroy extravillous trophoblast. Furthermore, the secretion of growth hormone and cytokine is also compromised. They will reduce the invasion of UETs into the decidua. Ultimately, abnormal uterine natural killer cell fail to promote remodeling of the spinal arteries. This event lead to implantation failure or due to impaired pregnancy maintenance, eventually resulting in miscarriage. There is very good cross-sectional study that demonstrated that the level of peripheral natural killer cell, that is CD56 and CD16 plus, cell in women with IVF failure was significantly higher than those with successful IVF. Another study also demonstrated that the density of uterine natural killer cell in endometrium from women with recurrent implantation failure after IVF has got significantly higher, that is 14.5% versus 5% than in endometrium from control women. So we must say that uterine natural killer cell are detrimental like peripheral uterine killer cell also. The name itself suggests it is a killer cell. Timely shifting of T helper cell 1. I already wrote Th1 and Th2 is of utmost importance for implantation. And this is how they had mentioned the immunomodulation. During the implantation failure, Th1 cells are infiltrated at the decidua and regular trophoblastic invasion by participating in the tissue remodeling and angiogenesis. When the implantation phase is over, Th2 cell becomes dominant and promote allograft tolerance. A high Th1 Th2 cell ratio is linked to more than 4 times implantation failure and more than 2 times pregnancy risk. Tumor necrosis factor alpha concentration is also significantly higher in the group of implantation failure patients. This slide depicts very good that high Th1 and Th2, whenever there is Th2 response is activated, there is formation of asymmetric antibody, Longacting mechanism is not there, there is pregnancy conducive endometrium, there is formation of protective cytokines into the endometrium, protective interleukins are there, and they are protecting embryo. So patient with recurrent implantation failure has got higher presence of autoantibodies. Patient with RIF has got higher frequency of presence of autoantibodies like antiocardiolipin IgG, IgM, and anti-nuclear antibody in sera. The presence of anti-nuclear antibody in sera increases the risk of IVF even after IVF ET procedure. And you can see that patient with RIF has got high frequency of autoantibody like AGA. These all are there very high in our all patients. Antiphospholipid antibody affects implantation, placentation as well as early embryonic development and expect detrimental effect during pregnancy by directly binding to the trophoblast. A few studies analyzed the role of antiphospholipid antibody in the etiology of female factor infertility. The prevalence of antiphospholipid antibody among women experiencing recurrent implantation failure, that is 9%, was found to be significantly higher than that in fertile women, that is 1.5%. Women with antiphospholipid antibody has a lower implantation rate of 14% than women without this antibody, that is 24%. So antiphospholipid antibody affects implantation, placentation as well as embryonic development and exert detrimental effect during pregnancy by binding with the trophoblast. Inherited thrombophilia. Thrombophilia is a condition where the blood has been elevated tendency to form clots, that is hypercoagulability. Microvascular clotting of vessels of the decidua during implantation due to hypercoagulability causes recurrent implantation failure in patient with thrombophilia. Various observational study has investigated the relationship between the inherited thrombophilia and RIF, and this study suggested that inherited thrombophilia may a major role of etiology in women with screen for thrombophilia. If you see, this study is very significant study by Cuban et al. And this study was done in 2006. It says it is very, p-value is very good, and they said that thrombophilia is also affecting in recurrent implantation failure. If we see the microbiome, in this X-ray, microbiome has got very good role, and this microbiota cell suggested that dominance of non-commensal bacterial community can weaken the integrity of the endometrial mucosal barrier. This in turn could lead further weaken host defense mechanism and allow pathogen to enter the endometrial stroma and elicit a profound immune reaction. Aberrant stimulation of T cell, either directly by invading pathogen, reaching the mucosal barrier, or inherited by absorbed bacterial products, result in disturbance in cytokine production in favor of pro-inflammatory Th1 cytokines. And we already said when there is Th1 is activated, there is inflammation and there is abortion. Dysbiosis is linked to a spectrum of clinical disorder related to the female reproductive system, which has been depicted in this figure. You can see this uterus has got very bad implantation potential. It can go for preterm labor, it can go for RIF, chlamydial, and can cause ectopic pregnancy, and bacterial vaginosis and STD can weaken the endometrium and weaken the host mechanism and disturbance in the cytokine production. Believe me, this thing is not going to happen in Indian community because we are taking very good curd and ghee and we are taking buttermilk. This is full of very good lactobacillus and this will protect our vaginal endometrium and we don't have to take any endometrial product from outside. This is very good study published by Th1 et al. And it characterized the microbiota in the environment of endometrial fluid, vaginal fluid, and in the patient of recurrent implantation failure. The Shannon index of EF, that is endometrial fluid microbiota, in recurrent implantation failure wood was significantly lower compared to women with RIF possesses a different microbiota. If you see the microbiota in control, they are very good compared to recurrent implantation failure. If you see in endometrial fluid, if you see in vaginal microbiota, so we advise all our IVF patients to take one full glass of curd or bowl of curd every day to increase the biometa in their product, in their body. This study with endometrial fluid from 35 infertile Caucasian women with recurrent implantation failure and then analyzed the impact of endometrial microbiome on reproductive outcome. Non-lactobacillus dominant, that is more than 90%, endometrial myobiota was found to be significantly correlated with adverse reproductive outcome measured as implantation, pregnancy, ongoing pregnancy, miscarriage rate, when compared to subject presenting with lactobacillus dominant, more than 90% endometrial microbiota. The study significantly highlight the presence of endometrial myobiota in environment. So you must see that in live birth, if we should be have got very good lactobacillus in our body, and for that simple thing, rather than taking tablets, one full glass of curd every day when we are planning our pregnancy. Chronic endometritis. Studies have demonstrated that high prevalence of chronic endometritis in patients with recurrent implantation failure ranging from 15 to 60%. In CE, the immunosuppression required for embryo transfer implantation is converted into the immunoreaction, which hampers the embryo to implant, and we can see that this figure, the pathophysiology, is related with chronic endometritis, and this will make embryo not able to implant inside the uterine cavity and hampers the embryo implantation when there is chronic endometritis. Likewise, endometrial thickness. This is retrospective study by in 2018. They observed that 105 women with regular menstrual cycle undergoing first natural IVF cycle, IVF NC cycle was analyzed. Clinical pregnancy rate, not H, and live birth rate, H, were measured as a function of endometrial thickness. The pregnancy rate in women with endometrial thickness more than 7 mm was 7.4%. 30.8% of pregnancy with endometrial thickness is equal to 7 mm. The tendency of lower pregnancy rate was observed in women with thin endometrium around less than 8, as well as particularly thick endometrium more than 11. So this study suggests that thin endometrium should also be considered an independent negative prognostic factor in achieving the pregnancy. So it should be ideal, very good around 7 to 8, rather than not going for 11 or 10. Whenever this is also increasing endometrium size, pregnancy is not going to be survived. Likewise, anatomical factor, submucosal fibroid are associated with more than 70% odd ratio of pregnancy and delivery loss. Likewise, polyp, patients subjected to polypectomy have got significantly increased. Intrauterine invasion or synecdoche has occurred in patient of recurrent implantation failure, and with very good lateral metroplasty by hysteroscopic adenolysis will definitely increasing the live birth rate. Hydrosalpinx, we must cut the tube because this hydrosalping fluid is detrimental to our patients, to our embryos, that is we are putting inside the uterine endometrium. Several genetic abnormality, several single nucleotide polymorphism, that is SNPs, have been reported to be associated with recurrent implantation failure. Tumor protein P53, genetic polymorphism R7 arginine polymorphism. P53 gene is more frequent in RA patient compared with the fertile population. HLA-G, that is human leukocyte antigen G, gene polymorphism, that is HLA-G of 14 BP polymorphism is significantly correlated with IF occurrence with odd ratio of 1.74. VEGF, that is vascular endothelial growth factor, women carrying genetic variant of VEGF genes are at significant risk of recurrent implantation failure. Sperm is also not going to be a good, and if it is not good, then they are taking part in recurrent implantation failure, and most important is DNA fragmentation. There are inherited factors in sperm factor like immature sperm, defective sperm, prolonged stasis in epidermis, abnormal protomination, abnormal cytoplasmic ROS with the antioxidant, and this all make oxidative stress. Environment factor, we had already talked about the smoking, radiation, alcohol, heavy metal, pollution, advanced age. They are coming to us when they are of not reproductive age. Systematic pathogenesis, lymphoma, systemic disease, and nowadays more common is diabetes. If patients are on some medication, ART related products or genital tract pathologies, these all are responsible of a sperm morphology are taking part in recurrent implantation. What are the investigations we should carry out in our patients? There is battery of investigation. First, we must look at our 50% population of sperm. We should see for sperm aneuploidy, sperm epigenetics, computer assisted ASA or DNA fragmentation. For oocyte, we have to watch for AMH. We must go for parental karyotyping when there is high order of recurrent implantation failure. So we have to see that if there is definitely some chromosomal abnormality, then we should change the gametes. Endocrine factor, thyroid, thyroid function test, prolactin, free androgen index, and HbA1c for diabetes. We must see 3D ultrasound of the uterus, and recently we had published paper, 3D ultrasound virtually looking like hysteroscopy, so we should not have to go for hysteroscopy examination when we are doing very good 3D ultrasound. Immunological disorder and thrombophilia like uterine natural killer cell, peripheral natural killer cell, endometrial cytokines, genetic microbiomes, peripheral blood cytokines, HLA compatibility, inherited thrombophilia, and antiphospholipid antibody. Now, what is therapeutic intervention? We are talking about investigation. Ultimately, patient wants good baby. So let us move on this therapeutic implantation. For therapeutic intervention, we must require optimum IVF treatment, antithrombolytic agents, immunotherapy, and antibiotic for infection. So for optimal IVF treatment, we must require very good embryo, we must adopt very good transfer method, and we should have very good ovulation induction protocol so we can get very good embryo or very good womb at the time of pickup, and we must give very good progesterone support. Why should we give progesterone support? Because when we are picking the ovum, we are also not picking the ovum, we are also picking the granular cell, and this granular cell are mother of progesterone. So if granular cell production is not good, then progesterone will be deficient. So we have to give very good progesterone support to all our patients in IVF. Let us understand the embryo factor for optimum IVF treatment. If we compare fresh embryos transfer, pregnancy resulting from frozen embryo transfer are associated with lower birth weight, preterm delivery, small for gestational age baby, placenta previa and placental abortion. There are a lot of questions that now world is moving toward the all free cycle or freeze all cycle. We have to see that this, if we compare with fresh cycle, then it is not very good. But if we compare the embryo cycle, the woman with polycystic ovary, in which we are getting very good high fecundity or higher birth, higher embryos, then FET is good. In patients which are undergoing PGDA, they have got significantly higher rate. Compare with those patients we have got very high responder, and we don't want to go for ovarian stimulation syndrome or OHSS. In this type of patient, in this group of cohort, if we do freeze all, then it is very good. But ultimately, old is gold, fresh transfer is good compared to frozen start. In respective of cohort study, pregnancy outcome in patient who had got cleavage stage transfer, where age matched with patient who has got day 5 transfer, it was observed that cleavage stage transfer was associated with significantly lower implantation compared and live birth. So ultimately this proves that when we are doing our blastocyst transfer, then all blastocyst transfer are very good. So woman with limited number of fertilization embryo by IVF in ICSI, preceding the cleavage stage transfer resulted in lower implantation rate compared to day 5 transfer, that is blastocyst transfer. You see everywhere blastocyst transfer is very good compared to implantation, live birth, miscarriage and twin pregnancy rate also, because here we are also only putting one blastocyst at a side. What are the different method of transfer recommendation? Abdominal ultrasound guidance is always preferred. We must remove the cervical mucus. We must use soft catheter. Immediate ambulation once the embryo transfer procedure is complete. That depends individual perception. Somebody wants to sit for 5-10 minutes, but it is not that much required. Placement of embryo at the tip. This is utmost important. We should put our embryo at the maximum implantation potential point, that is MIP point. Every uterus has got different MIP point. If we take the uterus of arcuate, if this two line is going over there, this is from the tube, and this point when they mix, because usually embryo dips into this cavity, into the ocean of endometrium at the maximum implantation potential point. Likewise in unicoordinate uterus, only one tube is there, so it might be little bit low. Particularly in bicoordinate uterus, it might be very low here. So before going for transfer, we must see that where is the maximum implantation potential point, and we should put embryo at that particular site. Then we see this 2021 study of systematic review and meta-analysis published from 11 different studies. Yanget et al. Evaluated the effectiveness and safety of long-acting GnRH releasing, that is GnRH agonist and antagonist ovulation induction protocol. 1994 women, those who are following with the long-acting GnRH, that is gold standard follicular protocol. 1678 women with GnRH antagonist protocol. And they are compared with live birth rate, clinical pregnancy rate and implantation rate. The incidence of OHSS was significantly lower in women undergoing GnRH antagonist protocol, and that is pretty much sure, because we are knowing that antagonist doesn't give that much of OHSS. But the live birth rate, clinical pregnancy rate and implantation rate was significantly higher in long-acting GnRH protocols against old is gold. So long-acting GnRH agonist protocol is beneficial in improving clinical pregnancy rate, implantation rate and incidence of OHSS is very low in patient with antagonist protocol. So we have to see our patient, that in which patient GnRH long protocol is good and in which patient our antagonist protocol is good. Progesterone, the hormone which is produced by corpus luteum. Hormones got its name progesterone. It is needed for gestation. We have to thank our mother that our mother has generated enough amount of endogenous progesterone, so no exogenous progesterone should be required. Progesterone is produced by corpus luteum and lately by placenta, has effect very good on secretory endometrium. It is necessary for implantation of early development of fertilized ovum. In response to progesterone, glands become tortuous, secretory, and there is increase in stromal vascularity, thus making the endometrium both morphologically and functionally well prepared for implantation. And we can call it as a pregnancy conducive endometrium with very good pinopodal activity, very good alpha V beta 3 integrins and osteopontin activity, and tract of endometrium should be 7 to 8, ready for implantation. Progesterone. The support with anti-inflammatory role of progesterone. Progesterone plays a significant role in establishing an adequate immune environment at the early stage of pregnancy. It exerts immunological pregnancy protective effect in part manifested by controlling cytokine production. Progesterone deficiency has been associated with insufficient endometrial maturation, adequate regulation of inflammatory cytokines. Thus, support with progesterone may be helpful in establishing a sufficient immune response in early pregnancy to prevent miscarriage. So, support with progesterone is established immune response in early pregnancy to prevent miscarriage, because it has got very good pregnancy protective mechanism because it is progesterone. Different variety of progesterone available in market. Oral micronized, low bioavailability, intramuscular, causing injection pain. Micronized vaginal progesterone, altered immunity such as vaginal irritation, and sometimes discharge can cause irritation, and sometimes tablets are of such a color that patient can feel that there is bleeding. Oral dydrogesterone, potentially oral progesterone with improved bioavailability. If we see this micronized and dydrogesterone, both somebody has stated natural micronized and synthetic dydrogesterone. Believe me, this dydrogesterone and micronized progesterone all are bacha of one mother, that is Discoria villosa. These are plant origin. Procata is coming from plant. If we are going for small micronization of this progesterone, small micron less than 5 micron, then it is called a micronized progesterone. And we are going for bond breaking, then it is called dydrogesterone. Bond can be breaked by chemical, by proton bombarding, and by electricity. Oral dydrogesterone is the right choice of progesterone because it has got high selectivity, highly selective progesterone due to its retroprogesterone structure, because it just behave like progesterone and bind almost exclusively to all progesterone receptor. It is better bioavailable, requires 10 to 10 times lower compared to doses of endometrial patient. You want to give vaginal micronized progesterone, then it should be 400 to 800 compared to 10 to 20 to 30 milligram of dydrogesterone. It has got very lower side effect, no affinity for androgenic, estrogenic, glucocorticoids and mineralocorticoid receptor. Its favorable safety and tolerability profile in pregnancy, both mother as well as child. So dydrogesterone has got documented evidence of immunomodulation. It is required for normal pregnancy because there is progesterone receptor activation. Dydrogesterone induces PIBA production, increased pregnancy progesterone induced blocking factor, that is PIBA. It blocks the cascade of shifting of T helper cell 2. Dydrogesterone induces Th1 to Th2 cytokine shift, that is from abortive to protection shift. That should be, because of that there is embryo protection implantation, immunomodulation, and protects the embryo. Ultimately what we want, improve pregnancy rate and decrease threatened abortions. In threatened abortion, if there is a threat, you have to give 40 milligram state dydrogesterone followed by 20 milligram till bleeding stops, and we have got very good result, and we have published more than 600 patient study on this dydrogesterone molecule. Immunomodulation. Dydrogesterone drives immunomodulation either directly or via the production of progesterone induced blocking factor, which mediates the immunomodulatory effect of progesterone during pregnancy and induces a cytokine shift towards the production of Th helper 2 cell cytokines, that is pregnancy protective immunomodulation. Dydrogesterone not only causes inhibition of natural killer cell cytotoxicity but also facilitates condition conducive for pregnancy. Dydrogesterone not only provides optimal secretory transformation of endometrium and also provides systemic immunomodulation, which is important for protect the fetus as well as it expresses antigen foreign as a maternal immune system. As I already told that Professor Raj Raghupati has given very good notion of allogenic immune response to paternal incision. And this dydrogesterone increasing in Th1 cell. There is very good study by Simonichin et al. That collected blood from umbilical cord of the patient in which they had given dydrogesterone up to 34 weeks of pregnancy, and they found very good P receptor positive cell or positive progesterone cell into this maternal circulation. And believe me, these cells are there and they are causing nitric oxide production, so they are giving very good vascularity. We all know that when arginine is converting into citrulline, there is production of nitric oxide, and this nitric oxide is nascent vasodilator and it will give pregnancy positive immunomodulation. This is Professor Howard Carr and Professor Raj Raghupati, and we had got very good discussion when they had came to India in Pune. In addition to bioavailability and receptor binding activity as an pivotal pharmacological features, the rapid degradation of orally administered progesterone results in high concentration of circulating metabolites. The progesterone metabolites circulating at high level and may bind to progesterone receptor and interfere with normal progesterone action by interfering with transcription receptor of DNA binding. Alternatively, the 5-alpha and 5-beta reductase progesterone pregnenolone are also to have high affinity for gamma antibiotic acid, that is GABA receptor. Such receptors are present in reproductive tract and their activation may adversely affect the pregnancy outcome. It is also known that dydrogesterone, the orally administered progesterone, upregulate the production of Th2 cytokines and downregulate Th1 cytokines. Interestingly, the metabolite, that is dihydrodydrogesterone, that is DHD, like to be parent molecule of dydrogesterone, suppresses the production of pro-inflammatory cytokines, the tumor necrosis factor gamma and tumor interferon gamma and tumor necrosis factor alpha, and upregulated the production of anti-inflammatory cytokines, that is interleukin 4. Dihydrodydrogesterone retain immunomodulatory effect of dydrogesterone. Dihydrodydrogesterone also induces NO synthesis and consequently improve the uterine subendometrial blood flow, increasing uteroplacental circulation and improves endometrial receptivity and pregnancy outcome. That's why in so many cases, when there is a pregnancy-induced hypertension or PIH, when vascularity is very low, in this type of patient, we are giving dydrogesterone up to 34 weeks, and believe me, we have seen very good result. There is little bit increase in the oligohydramnios, little bit increase in the vascularity of RI and PI of uterine artery as well as the umbilical artery, and little bit increase in the weight, and this is very good because of this is nitric oxide activity. So progesterone upregulates the HLA-G expression through a novel progesterone response element. By generating regulatory cell and modulating the effect of dendritic cell, T cell and neutrophil cell, increased expression of HLA-G might contribute to a favorable microenvironment in the testicula. Thus, one of the sites for progesterone action is promoting normal gestation in regulation of HLA-G expression. So this is also very good. Progesterone also upregulate the HLA-G expression in favoring the microenvironment and testicula. It's not that Manish is saying that's why it is that. So dydrogesterone has got so many clinical evidence. Here there are reference. There are meta-analysis can prove that dydrogesterone has got higher pregnancy rate and compared to microvaginal progesterone. Cochrane says there is no difference in live birth pregnancy rate, ongoing pregnancy rate between the synthetic and microvaginal progesterone. Synthetic pregnancy group has got higher clinical pregnancy rate. Randomized trial, oral dydrogesterone is well tolerated compared to progesterone with similar safety of micronized vagina. Phase 3 trial, that is a Lotus trial, oral dydrogesterone 30 mg has same efficacy as micronized vaginal gel and can be tolerated very well. Oral dydrogesterone leads to very high rate of clinical pregnancy rate compared to micronized progesterone. There is 8 randomized control trial comparing dydrogesterone and micronized progesterone in luteal phase support in patients who are undergoing artificial reproductive techniques. Total 308,009 women undergoing ART taken luteal phase support. Dydrogesterone group has 1,223. Likewise, micronized has got 2286 patients. Micronized vaginal progesterone and oral dydrogesterone were found to be associated with improved clinical pregnancy rate compared to micronized and did not affect the ongoing pregnancy rate. Study also suggests that oral dydrogesterone is better option in luteal phase support and it leads to higher pregnancy rate compared to micronized progesterone rate. So micronized is also, so dydrogesterone is non-inferior to the micronized progesterone rate. What Cochrane library says. Cochrane review was conducted to determine the relative effectiveness of various types of progesterone for luteal phase support in subfertile women undergoing ART. No difference was observed in live birth rate or ongoing pregnancy rate between dydrogesterone and micronized progesterone, but dydrogesterone has got higher odds ratio compared to micronized progesterone, highest odds ratio of clinical pregnancy rate. So dydrogesterone is better option for luteal phase support in patients who are undergoing ART. This is Lotus 2 trial. Objective was to establish a non-inferiority trial of women undergoing ART. Study population, they had done randomized open label. This is the first study, double blind, double dummy study. Micronized randomized open label multi-center parallel group of non-inferiority at 37 different centers, and in India there is one center. Non-inferiority analysis, pregnancy rate was done at 12 weeks of gestation. Live birth rates also compared in both groups, and the proportion of subject at least one treatment associated adverse effect in dydrogesterone compared to micronized progesterone. Oral dydrogesterone is very well tolerated due to progesterone with similar efficacy and profile than of micronized vaginal progesterone. Oral dydrogesterone was also conducted in women of 239 in Young by et al. In 2020. This is Chinese Maryland subject from the overall study population of Lotus 2 trial who were randomized to oral dydrogesterone 30 mg compared with 8% of micronized vaginal death, that is 90 mg daily from the oocyte retrieval till 12 weeks of gestation. There was a difference of 9.4% in favor of oral dydrogesterone with ongoing pregnancy rate of 12 weeks gestation. This study also demonstrated that 30 mg dydrogesterone has got same efficacy and safety as micronized vaginal gel and can be a good choice for all our patients to support IVF. So this is little bit messy when we want to put that every day we want to put gel rather than taking 3 tablets of dydrogesterone has got the same effect and it is non-inferior. What are the guidelines available in European? For European Club, for women presenting with clinical diagnosis of threatened miscarriage, there is reduction in the rate of spontaneous miscarriage if you use dydrogesterone. For presenting with clinical diagnosis of recurrent miscarriage 3 or more, the reduction rate of miscarriage with the use of dydrogesterone. Our own Foxy, that is Indian oral dydrogesterone 10 mg BT, my notion is 20 till 20 mg dydrogesterone 20 till 20 week of gestation, so 10 mg BT, that is 20 till 20, and we had given so many presentations because India is very fond of IPL 2020. And I am fortunate that this Foxy position was assessment was published in 2015. I am that in the team of National Task Force, and recently we had done progesterone guideline in endometriosis. I am fortunate that I am also in a team of this endometriosis trial of progesterone, and this is phase 3 trial, and we have got very good discussion with Professor Grishankar about the same phase 3 trial, and now this progesterone should be given to our patient. We all know that women with less than 35 nanogram of progesterone are 23 times more likely to experience miscarriage. As per recommendation of the study by Araben et al., oral progesterone, namely dydrogesterone, are well tolerated and effectively reduces the miscarriage in women with the risk of threatened and idiopathic recurrent miscarriage. While Lee and et al. Says that progesterone therapy, especially oral dydrogesterone, effectively prevents miscarriage in pregnant women with threatened abortion than control group. I am happy that this study was published by Manish Pandya and et al. And this is published in 2016 before Grishankar has published this study. This is study published in Open Access Journal. It published in 2016, and we had compared different population of dydrogesterone, different population of progesterone. There are 31 clinical trials starting from 1980 to 2015. And we had suggested that what is the optimal route, what is our goal, and ultimately we had proven that dydrogesterone has got little bit higher age in IUI as well as in IVF if we compare both. So there is the same findings were there in Grishankar's publication, and this is a a review study. And I'm happy that after publishing that paper, 500 copies was asked by American library. So in 2019, ASHRAE recommended guideline that in IVF and ICSI, dydrogesterone is recommended as a patient-friendly tool compared to progesterone. Dydrogesterone has got similar pregnancy rate, well tolerable, and better patient compliance. So dydrogesterone we have to use, but we have to choose right dydrogesterone because in India there are more than 80 companies are marketing dydrogesterone. So innovator dydrogesterone is very good and rich in legacy of 16 years by the right choice. It was there in market before 9 years. I born in Luxembourg, currently available in more than 110 countries. Demand are grew in last few years. Only one center, that is VIPS, that is produced, and only company has know how to produce dydrogesterone because it is 60-year-old product, and this bond breaking was done by electricity. And believe me, I am fortunate to visit this place twice, and I have seen that the electricity which is required for making this dydrogesterone was a one-day electricity of whole Amsterdam. So this much electricity should be required, and this is second visit at this WIMS facility. We must treat anti-thrombotic therapy. This is a systematic review and meta-analysis of more than 3 studies. They evaluated the effect of low molecular weight heparin, that is LMWH, on pregnancy outcome in women with RIF, those who are undergoing IVF. The study included 243 women and 123 women in investigation group. The concomitant use of LMWH was associated with 79% improvement in live birth rate and 78% reduction in miscarriage rate, and a non-significant trend towards improvement in implantation rate. The result of this meta-analysis demonstrated that women with RIF, the use of LMWH as an adjuvant to IVF treatment significantly improves live birth rate and miscarriage rate. In all our patients of proven antiphospholipid syndrome or APLA, we are giving this up to 34 to 36 weeks, and this injection should be given daily. We should stop before 48 hours or before 1 week of planned cesarean section, and believe me, this is very good molecule and this is making very good pregnancy outcome. Likewise, immunotherapy. Various studies have evaluated the effect of several different immunotherapies to increase the implantation. There is tacrolimus, PBCA, CSF, platelet-rich plasma implantation. These all are summary with clinical pregnancy rate as well as control. So we can give this treatment option of platelet-rich plasma in our patient, and recently we had found Ovarian Rejuvenation Society, and in which we are doing study of implanting this PRP in uterine endometrium, particularly in the cases of thin endometrium. Antibiotics for chronic endometritis. Women with CE has lower pregnancy rate, implantation and live birth rate. So antibiotic treatment significantly improves the outcome in IVF. If you see the implantation rate without antibiotic is very low compared to clinical pregnancy rate and live birth. So antibiotic treatment should be there, and that should be given after the culture sensitivity, or you can give time tested doxy and metrogyl on this group of patients. This is proposed algorithm that how should we treat our patient with recurrent implantation failure. We should give optimized lifestyle, we must give psychological support, we should rule out all genetics, we do all routine investigation like histoscopy and everything to rule out uterine anatomical abnormality. Endocrine we have to see. If PGD and PJD should be there. Histoscopic resection of endometrium, implants, septum, resection, everything should be there. And only in context of design research, we have to give treatment of thrombophilia. We should treat our patient with immunological causes. And sperm is defective. We have to treat sperm with sperm DNA fragmentation abnormality. We have to see 22 deletion in our sperms. So this is the proposed algorithm. So we have to treat our patient. Patient should be there with very good endometrial receptivity. Embryo should be euploid. We should take soft catheter, ultrasound guidance. Always implant in maximum implantation potential point. After treatment, if there is ovum donation, we have to counsel the patient. If the treatment is not there, we should also offer them the surrogacy and also offer all the counseling. And believe me, till date I had done more than 89 adoptions, and it is very good service to humanity. So don't say that there is no option left for them. So RIF is complex problem with wide variety of etiology as a mechanism as well as treatment option. Women with RIF should be offered appropriate investigation to rule out underlying causes for repeated failure. The main treatment strategy in couple with RIF is to improve the quality of embryo transfer and receptivity with the endometrium. Identifying the risk factor, give the treatment, and always individualize the plan. Immunomodulatory effect as well as positive pregnancy outcome of oral dydrogesterone make an effective option for progesterone support in luteal phase patient. So when men need this difficulty because they are necessary to enjoy success, said by APJ Abdul Kalam, and I am happy to share that APJ Abdul Kalam has also received the Dynamic Indian of Millennium Award from KG Foundation, and I had also received the same. Thank you, sir. These are some GIF made by different company of dydrogesterone. So did you know dydrogesterone is superior? Did you know dydrogesterone is superior? You know dydrogesterone is completely, and all are got used 2016 paper as comparative evidence. So ultimately, end of the day, we should not require any recurrent implantation failure in our patients, and this should be the notion. The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. Our patient at the end should be very happy, and we must give very good heavy rate to our patient, and we should treat all our patients of recurrent implantation failure individualized. Thank you very much. Thank you, Abbott, for giving me opportunity again and again to do webinar. Thank you, sir. Any questions is most welcome. Now just I am stop sharing my screen. Jignesh, if you see any question on chat box, I am ready to answer.
Thank you, but there are no questions are available in chat box, sir.
Thank you, Jignesh. You are looking smart on this screen. So thank you very much, Abbott, for giving me opportunity. Thank you, sir.
Thank you, sir, for delivering such a nice answer, and thank you all the participants for their time.
Thank you. Just I am leaving the meeting. Thank you.